During the journey of pregnancy and birth, there can be many twists and turns that crop up along the way. And for this reason, many women will meet an obstetrician during pregnancy, during labour, or even after the birth of your baby. An obstetrician is a doctor who specialises in these specific areas, and they're there to support you to make informed choices and decisions about your care pathway. For some women, the idea of seeing an obstetrician feels a little anxiety provoking or concerning, that interventions may be recommended or they may be given labels such as having a high risk pregnancy. So on this week's episode, I am delighted to be joined by Dr Ellie Rayner, who is here to explain why meeting your obstetrician need not be an anxiety provoking experience, and to reassure you that we are all on the same team when it comes to your pregnancy and birth. Dr Ellie Rayner is an obstetrics and gynecology specialist doctor working full-time in Devon. She's also an antenatal and hypnobirthing teacher and the founder of the Maternity Collective. She prides herself on wanting to make obstetrics accessible and understandable, and is passionate about providing expectant parents with accurate, up-to-date and evidence-based information to enable them to make informed choices about their care. In addition to being a member of the Royal College of Obstetricians and Gynecologists, she has qualifications in medical education and health services improvement, and utilises all these skills to ensure women, at whichever part of their motherhood journey, feel supported to make decisions that are right for them and their baby. She's particularly interested in improving women's pregnancy and birth experiences and reducing the chance of complications, and feels that this involves comprehensive pregnancy and antenatal education, which should start even before conception. So welcome, Ellie, and thank you so much for taking time to join me today. I'm so excited to chat.
Hi Pip, I'm very excited to be here too. It's lovely to catch up.
It is, especially in this crazy world that we're currently living in, COVID-19. It's brilliant to see all the work that you're doing to help support women really navigate the kind of choices that they might be making. So thank you.
Oh no, it's my pleasure, and it's really lovely to chat today.
Brilliant. So Ellie, I wonder if you could just kind of summarise for everybody listening what your kind of role as an obstetrician looks like.
So an obstetrician is a doctor who specialises in pregnancy, labour and birth. So being that we've been to medical school like any doctor would have, and then we've chosen particularly to specialise in women's health and in pregnancy and the period after birth. So our role is often to look after ladies and women whose pregnancies are deemed a little bit higher risk. So ladies that might be at risk of complications. And that could be anything from having a medical condition that they know about already before they even fall pregnant, such as maybe diabetes or epilepsy, or that even could be something like their pregnancy being more complicated this time because maybe they had a previous cesarean last time. It could be also to do with if we know that there's a risk that their baby could be at high risk of a complication. And again, we're here to support them and to help them on that journey and to help them feel like they're in safe hands, and about providing ways to reassure them and to make their pregnancy as safe and as healthy as possible. This is something we do every single day. We're all trained in obstetrics and gynecology, so all aspects of women's health. So lots of times you'll meet an obstetrician who you might have met during your journey before you were pregnant, and that's a really nice thing. And we use those skills throughout our training to develop to transition women from their gynecology into pregnancy and then into motherhood and then into later life potentially, as they are women of all ages.
Oh, that's lovely. So your role really is all about sort of everything women's health, I suppose, isn't it? And that whole kind of journey. But then we have this really exciting, certainly in my opinion, as a midwife, part in the middle, which is that pregnancy, birth and motherhood stage. So Ellie, that sounds really exciting. So I can totally see why you were drawn to a career as an obstetrician. But in your opinion, kind of what made you decide that that was the right path for you?
So I think we as obstetricians and gynecologists, lots of us do stay very general, but a lot of us do tend to find an area that we're particularly keen on. And for me, that's definitely obstetrics, and that's definitely the pregnancy journey as part of a woman's life cycle. And for me, that actually started all the way back at medical school. So I went to train at Exeter University, and we actually learn medicine in a life cycle. And the first thing you learn in the first few weeks is you start with conception, and you start with the anatomy and the physiology and to do with genetics and all parts of the body to do with reproductive health. And that was the first thing that we learned at medical school where I trained. And actually that really inspired me. And whether it was because I was at a new university and I'd moved away from home and I was excited to be there, or just because I was excited to be learning, but I found it the most exciting couple of weeks, and it really inspired me. And I thought, I love this. This is really interesting. I think this is really exciting. And I was excited to hear about the different conditions that we would learn about and how to treat that. So that started way back in the first month of medical school. I was like, actually, this is what I want to do. I like pregnancy, I like conception, and we learned about normal and the normal process of labour and pregnancy and birth. We learned about physiology and about how our bodies work during pregnancy, and that has stuck with me for a really long time. And you flirt with other specialties on your journey, and you maybe think, oh, maybe I'll think about paediatrics, but actually obstetrics really drew me, and it drew me to that point of working with expectant parents on what is the most exciting part of their life. And I know you'll know, Pip, as a midwife, we get to work with women and their partners at this incredible time where they transition in their lives from having a baby that they've nurtured and grown for all those months to it being a real person. And we see that transition, and we're in such a privileged position. I couldn't imagine doing anything else. And I think we as obstetricians have such a wonderful job, and midwives, we're in such a position to work with families. And as an obstetrician, you see the medical side of pregnancy sometimes, but we do also get to see that normal pregnancy, labour and birth experience, which for so many women is a pivotal point in their life. And what a more magic thing to do every single day of the week than do that. So it definitely attracted me quite early on. I've never been able to shake the buzz of labour ward, and still every time, and I'm sure you're the same, every birth still excites me and find interesting, and every pregnancy is so different. It's still a great thing to do whatever day of the week it is, and I can't imagine doing anything else. So I really feel like I found my purpose. I think obstetrics is a passion for many people, and I know midwifery is as well. Lots of us have to be very engaged with it. You take it home with you spend your whole life thinking about it, and it's a specialty that does attract a lot of people that are really passionate about making a big difference.
Amazing. And we are so grateful, Ellie, that you have gone down the kind of journey that you are. And I'm sure I speak for plenty of women that you have supported and helped in their journey. And I totally echo what you said. I mean, when these little ones come into the world, it is just the most magical experience, isn't it? And to be part of that and to be able to support these expectant parents is just amazing. And it's something that no matter how many times we are involved in that and we witness that, it always kind of captures your throat a little bit, doesn't it? It's always beautiful.
It does. And I can still remember being a medical student and watching my first ever birth, which actually did happen to be a water birth. It was on a delivery suite, and I can still remember how I felt, and I can still bring myself back to that exact moment when I realized how incredible that was. And just as an observer, and I was so grateful for the couple for letting me be there, but that really, I'd love to meet them now to tell them they actually inspired someone to go on and pursue that as a career. And I can't imagine how many births I've been at now, but I can still take myself back to that exact moment that I first saw a baby being born. And I hope I never lose that. And I hope I never, like you, ever get to lose that excitement of doing what we do, because it is such a wonderful job, and it's a job that I feel really proud to have. And I tell everybody what I do because I'm really proud of it, and I couldn't imagine doing anything else. I'm very glad I didn't do A&E or pediatrics or any of the things that at one point I thought I might do. But it's a job that I think, and you'll know as well, has really powerful highs and lows, and they are still worthwhile every second doing, because I think we get an opportunity to make a difference. And I'm not sure many people can truly believe that. And I do think we do get that opportunity in the job that we do.
Yeah, definitely. And every single day, like you said, is different, which is wonderful. And I suppose when we talk about how special this moment is for expectant parents and how it's not just one day birth, it's something that parents will carry with them for the rest of their lives. And that's why it's so important that we make this a positive experience. And I know you are as passionate as I am about making sure that regardless of whether this doesn't go to birth plan A, and there are some twists and turns or some medical interventions that are recommended, it can still be such a positive and empowering experience birth, can't it?
I think absolutely. And I think we have to move away from thinking that anything but a calm, unassisted birth is a really positive birth experience, because I think there are many forms of birth. And I think all of them can be really, really positive. There are elements of perfection in all births. And there are some births in which do stray a little bit from their original plan, but that women and parents and couples still look back on with really fond memories and really regard as still the best day of their life. So I think so. And as an obstetrician, I would say that, you know, probably the majority of the births that I'm involved in are not on someone's birth plan. Not many people would like forceps on their birth plan. But
I'm yet to see that either.
I haven't seen it. I'm waiting for the day. Probably not going to happen. But it's really wonderful that we can maybe take an experience which is slightly straying, but still bring it round to a positive one where mum and baby are safe, and the experience is something that they would be proud to talk about and discuss with their friends and family and look back on with fond memories.
Yeah, absolutely. So, Ellie, in your kind of day-to-day role, I say day-to-day, day and night role as an obstetrician, what are some of the kind of common points in a women's journey that you might meet expectant mums and dads and start to kind of chat with them?
So I think there's three main occasions, and I think they could be, firstly, if it's a planned appointment. So a midwife or a GP might refer a woman and their partner to an obstetrician either before they're pregnant or during their pregnancy for an opinion on if something that's going on might need managing in a certain way to keep mother and baby safe in the pregnancy and optimize conditions. So if you've got maybe pre-existing diabetes, you might be referred before your pregnancy for a planned appointment to discuss how diabetes impacts your pregnancy. It may be during a pregnancy, a midwife identifies that you're maybe measuring smaller than expected with a tape measure, or that she feels that as you've had a previous cesarean section or a complicated birth, it may be worth discussing with an obstetrician if there's anything that should be put in place this time. So they would be planned reasons. So you should know about those appointments in advance, and you'd have an opportunity to come and have questions answered and information. And in normal times, usually bring a birth partner with you or someone to discuss or support you. We can still do that regardless at the moment by telephones. You could always call a supportive person to be on the phone if you needed to speak to them with a doctor. And then there's the more emergent or urgent occasions. So that might be if you've noticed that you've got a little bit of bleeding, or if you've got some abdominal pains or some tummy pain that's not quite right. Maybe your baby's not moving as normal, and you may not have planned to come and see us that day, but we are, like you as midwives, we are here 24 hours a day, 7 days a week. There would be a doctor who'd be able to see you, and it doesn't necessarily mean anything needs to happen or change or anything is worrying, but just for a review, potentially have a chat, have an examination, and just see how things are. And then there may be the third time, which is the time during your labour or your birth, that you might meet an obstetrician. Again, that might be a more unplanned or an unpredictable event where, again, your midwife has identified that she's got a reason, or he has, that they feel a doctor's opinion might be warranted. And that can be for a varying different reasons. But I think they're the three main times that you might meet an obstetrician. If you're having a low risk pregnancy and you're otherwise normally fit and well and healthy, you know, you wouldn't meet us. You would go through your whole booking, pregnancy, birth, postnatal period without ever meeting a doctor. And that is completely, normal for that to happen. But there may be occasions when you do need to come and see us, and we will be here to see you if you need us.
Amazing. And that's not a scary thing, is it?
No, I mean, I think there's always, I think obstetricians always carry, you know, the midwife might say, oh, I'm going to ask the doctor to see you. And I think that could cause some anxiety, but that's never because it always means something really serious. It just means that some things, the way we work with our guidelines and our protocols, need an obstetrician to say that they're happy for you to go home, or for us to arrange an appointment to follow you up in a clinic, and that would be our responsibility to sort that appointment out, or to arrange a scan, for example. And unfortunately, in most situations, that does require a doctor to do some of those things. So it might be that you see one and they just explain the plan. It might be that the midwife just discusses it with the doctor and you don't actually meet that obstetrician. But there could be lots of reasons, but it doesn't always need to be a scary, worrying thing that we're going to tell you any bad news or significantly impact your pregnancy. There can be loads of reasons that you meet us along the way and then you never see us again. And that's okay too.
Yeah, definitely. I suppose it's useful for ladies that are listening to understand that when they see their midwife is a specialist in normality. So when everything's going well, and then what we're looking for is detecting when things are moving out of that normality. And when that happens, they're moving out of our remit of speciality and into yours. So that's when we might say, we're going to get the doctor because this isn't my area of expertise anymore. This is Dr. Ellie's. So then you come in and kind of make that plan. And we're all working as a team, and our goal is all absolutely for that woman to have all the information and to be able to make her choices that are right for her. And we are absolutely working together for you.
And I think that's what a lot of parents don't understand, is that we do have this fantastic model of care in this country where we do have midwifery led and consultant led care, but they are completely intertwined. So everywhere that I've worked, if for whatever reason you referred for a consultant opinion, it doesn't reduce or affect any of your midwifery appointments. Usually you keep those alongside because they're still absolutely important, and you're still under the care of your community midwife team. They're still your initial point of contact for everything. We're just providing extra input. It's absolutely not a case of you become under a different team completely. I think it changes slightly how your care is delivered, but actually the midwifery element is so vital, because we don't discuss the same things in our appointments that every mother and expectant parent needs to hear along their journey. And I think lots of women get reverted back to midwifery led care. You know, they come to clinic and we're asked for an opinion and we say, actually, we don't think this has any impact on a pregnancy. We're really happy you can be looked after in the community by your team. And that's the last time we see I will always slip into saying patient, because as a doctor who's trained, I try and catch myself and say parent all the time, but sometimes I will say patient because as a doctor that feels the right word sometimes, but often ladies will pop back into midwifery care and we won't see them again, and that's a great thing too.
Yeah, definitely. It's just whatever's right for that journey. Now, for anyone who already follows you on Instagram, Ellie, and your Instagram handle is linked in the description, one of the things I absolutely love the most about the post you put out there is the way you explain risk in pregnancy and birth, and looking at statistics in different ways and making sure they're evidence-based. Because I think sometimes when we give statistics, we absolutely give the right numerical value or the right percentage, but we almost give it in a biased way accidentally. And actually, when we look at it in different ways, that risk might feel very different to somebody in the way it might automatically be presented in some of the literature. So I wonder, how do you recommend, and how have you got your head around kind of balancing those risks and benefits of maybe a recommendation of an intervention or a different pathway in pregnancy?
Well, this is one of my favorite topics, and I could talk about this a lot, so I will try and keep it brief. But really important for anyone that is pregnant, or even in any part of healthcare that's receiving information about risk. Now, a nicer word to use is chance rather than risk. But when you're discussing the risk and benefits, or the pros and cons, because that's what we're talking about often, everything will have a pro and a con. You can't escape that. And it's important to understand that there's different ways that you need to receive that information. So it's relatable to you. Now, there's two important risks, and they're called risks in medicine, so I will use that word to understand, and that's what's called the relative risk and the absolute risk. And these are two things that I'm going to explain because it's really important to understand. But the relative risk is the likeliness of an event occurring in a group compared to in another group. And this would be things like twice or double or 2 times greater the risk. So it's relating it. So for example, a really good one, and I am going to use an example, is what happens if your waters have gone at term for more than 24 hours, because this is a really easy example to use. And the other half of the risk conversation is the absolute risk. And that's what's the overall risk of something occurring in that situation. What's the actual number? And these sound the same, but they're actually really different. So, for example, if you take that breaking of the waters, the waters releasing around your due date, so after 37 weeks, and they've been gone for more than 24 hours, so you don't go into labour within 24 hours. In this country, you'll be recommended an induction of labour, and that's what we recommend. And that we recommend that because the risk of infection goes up to your baby. Now, actually, what you might be told is that the relative risk, so someone might say to you, oh, the risk of infection is double after 24 hours, and that's the relative risk. After 24 hours, the risk is double for the number of babies that will be affected by infection. But actually, the absolute risk, that number has gone from 0.5%, so that's 1 in 200 babies, to 1%, which is 1 in 100 babies. So you can say the word double, and that is absolutely correct. The risk has doubled. However, it's a bit misleading because lots of us think the risk is doubled. We can imagine in our heads a huge number, but sometimes those numbers in healthcare and in medicine and in maternity can be really small. Now, I'm not saying do or don't have an induction, but what I am saying is those numbers are really important to understand. You need to make sure you've got both of those numbers. So how does it change if you do or don't accept the intervention? But also, what's the actual numbers we're talking about? So for this situation, it's a really easy example, but there's other statistics that are nice to think about. So when you talk about vaginal birth after cesarean, you can say that 3 out of 4 women will have a successful vaginal birth after one single cesarean, but you could also say that that's 75%, or you could say that that's 75 out of 100 women. And I think it's really important as midwives and obstetricians is that we use all of these different words because they might mean something to someone that's the way they need it to understand. So because we all understand things differently, we need to work out, do they need it visually? Does someone want to hear it as a percentage? And is that a number that's going to really help them? Or is saying 3 out of 4 women will have a vaginal birth, or is saying the other way around? Some people want it the other way. So saying 1 out of 4 ladies will still end up with a repeat cesarean. And I think so much of the time, this is the bit we do get wrong in any healthcare, and I think you're the same on your platform. We try and explain these things in different ways because that's the important part of the decision making. What is the actual numbers we're talking about, and does whoever we're talking to understand what we mean? Because sometimes we truly believe we've explained it well, we truly believe we have given them all the information in a really clear way, and so often if you were to have that conversation an hour later and check back, it may be that you haven't explained it properly. So I don't know if that's helpful, but they're just a couple of the things. And I do regular posts about this because I think it's important to understand that difference between relative and using, oh, it's twice as much. It is twice as much, but find out what that bottom number is. What's the real number? Because for you, that number might be acceptable. It might be completely unacceptable, but that's because you're an individual and you're allowed to choose what's right for you.
Yeah, that's such an amazing point, Ellie. And I'm sure, hopefully a take-home message from pregnant ladies listening to this is if you are presented with a choice in terms of those risk numbers, then to ask for those in different ways so you can truly make an informed decision. Because if you don't understand the information, then that decision that you make isn't from an informed place because you haven't understood it. And it's important you're empowered to be able to do that. And that's all part of having a positive journey, isn't it? That parents feel like they're making the decisions with all the information that's right for them.
And I think that's what we have to be here to do. We're not here to tell parents to make one decision over another. We're here to make sure that we provide all the facts. And sometimes we don't know the numbers. So sometimes it's really difficult, and it's difficult to personalize those numbers. But if we do know them, and it's fair that we also admit if it's an area of research that hasn't happened yet, that we're not clear on the exact numbers, but these are the thoughts around what we're suggesting, and where we do know the numbers, using them in different ways and asking. So if you don't understand what someone said to you, just say, no one will mind going back over it. Just say, actually, I didn't understand. Can you just write it down? Can you draw a diagram? Do you mind just writing those numbers down somewhere that I can take away and I can have a look at? Or asking for the reference if you'd like to read it yourself, because that's another thing that you can do if you'd like all of the details and all of the information.
Definitely. And kind of on that, I would always say to women that always ask your healthcare professional for the reference rather than hitting Google, because there's a lot of inaccurate information that you could find on a basic internet search. So you're much better getting that resource from your healthcare provider, because they'll make sure they give you something that's kind of gold standard.
Absolutely.
And Ellie, I wanted to say, talking about making those decisions in pregnancy, how does your role as an obstetrician kind of fit into that? And how do you support women to make those informed decisions about their kind of pregnancy and birth choices?
So I think I'll explain what I do in my head, because hopefully that will help anyone listening to understand how difficult it can be sometimes. So I think for all of us, we've got a pair of weighing scales in my head, and I hope parents have the same pair of weighing scales. And when I presented with information and people asked me to recommend, what would I recommend, or I'm having to discuss the pros and cons or the risks and the benefits of different things, I imagine two little scales and I add different parts of the woman's history or the pregnancy journey so far, information we've got from scans or blood tests, things that the couple have written on their birth preferences also, and you add them to little scales and you imagine, well, this adds towards the pros and this adds towards the cons, because unfortunately you do have to personalize risks, and you can't just have a blanket rule for everybody and say, if you've had one cesarean section, a vaginal birth is the right thing for you, because there's lots of factors that will affect the way the pros and the cons are balanced on those scales. So I physically imagine a pair of scales in my head. So when I'm trying to work out what's safe, what's right, what's the best way to discuss options and to help parents come to a conclusion that's right for them, we have to talk through their own individual pair of scales and what they would like to put on them and what including in their decision making. I think you need to do the same. So if you're presented with an option or a discussion for you, for example, if the recovery, not being able to drive maybe for 6 weeks after a cesarean, that could be a really important thing for you in your decision making about having a cesarean section. If you live quite isolated, you don't have any support and you need to do the school run, that could be really important. If you don't drive, for example, another mother might say, well, that's irrelevant. I don't need to balance that on my scales. I don't need to worry about that risk. That's not something that's important in my decision making. So that's what I would say, is take each of the things you're being presented with and work out how important they are to you, how much you value them, how much, if that risk or that chance or that complication happened, how significant would that be to you? Because we're all different and we're all allowed to have an individual perspective of risk. And I think we shouldn't apply a blanket rule and say these are serious risks and many women wouldn't accept these, because actually some people are more risk averse than others, and all of our weighing scales, if we look at them, would look differently, and that's completely normal and natural. And I'd hope that even yours and mine would look different, and we base that on so many things, even from our personal situation and our previous experiences will affect how we make decisions, and it's okay that we recognize that.
I think that's a really nice point, actually, Ellie, for mums or parents listening to recognise, is that your obstetrician isn't just looking at you in terms of how that correlates to a textbook or the literature. We're all individual people, and that you're actually considering their whole social background and their psychological background, as well as the kind of physical presentation that might be in front of you with them as well. It's their whole picture, isn't it? And their preferences, like you said as well. It's taking that whole thing into account to make that individualised package of care for each mum and baby, which is what it's all about, isn't it? We're all unique, and that's what makes the world wonderful.
And I think that's lost a lot. I think people don't recognize that that's what lots of the decisions that we do. I see quite a few women who say, oh, my friend or my family, or I've spoken to someone else. And it's really difficult because that is absolutely correct. And how that decision was made for another couple or a friend or a friend of a friend or a family member will be very different, because every pregnancy is unique. And looking at maybe induction of labour around a due date, for example, that is very different if somebody comes in and they've got other risks or other complications in their pregnancy, or if their pregnancy has been very straightforward and has been completely healthy to date. Even those two patients, they could be on the same day with the same gestation of baby. We might look at those risks or those benefits differently because they are different. And I think we need to remember that at all times, that we can't look at a lady and not just take into that social and environmental factors that can impact partners. They might have preferences as well, so it's important to remember the birth partner at all times and what their thoughts are on the situation, because sometimes they are forgotten along the decision making process. And I think particularly at the moment it's important to remember to check in with them to make sure they haven't got questions, because they might not have been at an original consultation because of what's going on at the minute.
Yeah, that's another really lovely point actually, is that we're looking after that whole family unit, aren't we, and making sure it's positive for that whole family. Which is all kind of part of the joy of maternity. And I guess it's unique in that way, isn't it? That it's that real kind of family-centred care, which is lovely.
It is. I don't think many other areas of the hospital work in the way that maternity does. And that has amazing positives and negatives, because people either really understand how our maternity services work, or sometimes hospitals don't, because we are so unique how we operate and how we manage our services and work with those family units, recognizing that this is a journey for all of those parents on that journey. So I love it. I love it for that reason as well, because it's so nice working and looking after birth partners along their transition too. But as an obstetrician, I would be no good looking after a man medically. I can say that for nothing.
Yeah, I'm so with you on that. It'd be rubbish. Love it. So Ellie, we talked a little bit there about induction of labour, and I think, I don't know about you, but it's probably one of the questions that I find crops up the most when it comes to making decisions. And induction can be recommended for so many different reasons for each individual, can't it? But I just wondered if you could kind of explain what a conversation should kind of look like, and things that women should be asking and obstetricians explaining when it comes to navigating the recommendation of an induction of labour.
Yeah, and I completely agree. I think induction is something that lots more women are hearing as part of their pregnancy journey now. So I think it's important that women have thought about it earlier in their pregnancy, not necessarily waiting, just have an idea about the process. And the reason for that, because there's lots of occasions, and there are definitely lots of occasions that you may be recommended an induction during your pregnancy as a planned event. So from quite early on that the doctor has recommended that I'm going to be induced around my due date, for example. And that could be for different reasons. That could be for different medical problems or pre-existing pregnancy reasons that there's been that recommendation. So those parents know from a really long amount of time, they've had a lot of time to look at all the research, make decisions that are right for them, plan an induction, and even do the research that means that they've made the decision that they feel happy with. But there is occasions when there's a slightly more unpredictable element towards the end of pregnancy, where for whatever reason it wasn't the plan, and we completely understand that, but things do steer slightly from that pathway that raises a suspicion or a concern that an obstetrician feels that it would be safer to deliver your baby and to bring on labour rather than allowing the pregnancy to continue. And all of these things are absolutely your choice, but obstetricians tend not to make that recommendation unless the benefits of delivering baby and getting on with the birth do outweigh the risks of continuing the pregnancy. And I think that can be sometimes happen again as a slightly more plan. So maybe you come in and there's a level of suspicion that something may be developing that might be untoward, and they say we'd like to look and do some more investigations, but we might recommend an induction in the next few days. So again, you've got a bit of time. It's quite uncommon that someone would come in and on that same day we'd say we think we need to induce you now. That would be uncommon. It does happen, but in all occasions there should be time for you to be able to make a decision that's right for you. And in that, you should absolutely receive the exact rationale from the obstetrician looking after you. So why do they really recommend it? What are they worried about? What's their concern? How serious is that concern? Because everything's a spectrum, everything's a continuum. So there are certain things that are more worrying than others, but also it's important that you understand why, and that will help in your decision making, because just like we talked about, there's some risks that you might be happy to accept that another mother might not, and again, that's fine. And then it's important to make sure you understand what would your options be if you didn't want to proceed with the induction. And now that is something that is absolutely your choice. And I wouldn't want anyone to listen to this to think that whenever they meet an obstetrician and they're offered an intervention, that that's a decision being made. That's the start of a discussion, and every mother and parent has a choice about everything regarding their health, their well-being, and their maternity care. So at that point, it'd be really important to find out what would the alternative options be in that situation. So for example, if you didn't feel an induction was right for you, how would the obstetrician or the midwife make sure that your pregnancy continues as safely as possible? And that might often be something like providing extra surveillance or extra monitoring of you and your baby. And that's things that we can discuss, because that might be the right option for you, but equally you might prefer to go with the induction. So then make sure that you truly understand what the process would be, because every hospital does manage induction of labour slightly differently, and that varies on your medical and your obstetric history as well. So it's important that you find out how the obstetrician would plan that induction to work and how it works in the hospital that you're being cared for in, and at what point you would be expected to have your birth partner or not have your birth partner. That's an important consideration. And about when you'd come into hospital and when you'd be expected to go home afterwards. So those are the main things, just really understanding what the rationale is, what the options are, and what truly the process is, because then you can decide if it's right for you, feeling like you've made a choice that you understand. Because I wouldn't want anyone to go away afterwards and say, oh, I didn't quite understand that that's what this meant, because that would be really upsetting later down the line and could affect how successful your labour is if you did have a rise in your stress and your adrenaline.
Yeah, definitely. And that's a really great point. It comes back to that making informed choices, doesn't it? And having all that information and feeling empowered to do so. And I don't know about you, Ellie, but in my experience, even when there is some kind of twists and turns in a labour or birth journey, when women have been given all that proper information in a nice balanced way, like you described, and have truly made that informed choice themselves, kind of regardless of how their birth ends up looking, they generally feel really positive and empowered, because those are choices that they've made for them and their baby. And that's what's so important that we get right, isn't it?
I completely agree. And I think I've really noticed that over the last few years as I've become, more experienced, is that if you provide that balanced counselling and really facilitate a discussion and a decision that's right for that couple or those parents, then actually, if for whatever reason things do evolve during the situation, then that's still that they already feel like they're on the journey with you, and they're already on a pathway to something that they truly are happy to go down. And that's really important. And I think having that time to make that decision is part of that. So it's very rare that there should be a decision that you're asked to make that is very, very urgent. And if that's the case, that there's truly a risk to mother or baby, the obstetrician will be very forthcoming in saying, this is why I think we need to make this decision quite quickly. But in lots of situations, there will be time, and that time can be wonderful for you to have a conversation with your support network, to read the written information. So all hospitals will have written information about induction of labour. All hospitals will have information that you should be able to take away with you or finding a different format. So sometimes people need accessible information, and there is ways of accessing that. And there's other resources that are not produced by a hospital, so there's national guidelines that parents might want to refer to. And again, that's why I do advocate for thinking and looking into some of these things before you get to that point, just in case there's anything that you really don't understand or wouldn't be happy with. So you've got time to have that conversation with your midwife. And I'm not advocating everyone thinking at the start of their pregnancy, oh, what would happen if I was induced? But I just think recognizing that a number of women do have an induction of labour, and it may not be as helpful for them if they find that that's thrown on them at the last minute, and they may have preferred to just have a rough understanding of what that would mean slightly earlier.
Yeah, definitely. It's preparing ourselves, isn't it, for these eventualities. Now, one of the other things, Ellie, that quite often crops up, and I guess this is where sometimes that time scale can be a little bit more of a challenge, is the recommendation of an assisted birth or kind of a birth intervention in those final stages of labour. And yeah, I think that element of time can be a little bit more of a challenge sometimes at this point. So how would we kind of approach those conversations?
So this is actually one of my favorite topics, and it's one of my favorite topics because I think there's a lot of misconception surrounding instrumental birth, and now what we call now assisted vaginal birth, assisted vaginal delivery. And I really am passionate about this topic because I love being part of a woman's journey into helping her achieve a vaginal birth. Because for many women, if I meet them because a midwife has asked me to come and review, wondering if a mother does to have a discussion about whether an instrumental birth or an assisted birth would be suitable and would be recommended, that's not ever usually on someone's birth plan. So it's a really nice opportunity to meet a parent, but also we have to recognize, and it's walking into a room, that often it's very rare that a mother is excited that you have come into the room for that particular reason. There is a few occasions sometimes when someone's had a really long difficult labor, they're very pleased that we may be at a point where we're recommending helping with the birth of a baby to expedite birth, but often that's not the case. And it's really nice to be able to go into parents and reassure them about an assisted vaginal delivery, because I do think there are some misconceptions, and I think absolutely an assisted vaginal birth does carry slightly increased risk compared to a spontaneous vaginal birth. However, at that final part of labour, when you've come all that way, you've got all through the first stage of labour to fully dilated and nearing the birth of your baby, at that point, an assisted vaginal birth is usually is safer than a cesarean section at that point. So I think that's not something that many mothers or expectant parents are aware of. And I think it's nice to be able to go and have that discussion and talk through the pros and cons in a really balanced way, and some of the benefits that you have in that you can remain in the birth room that's been set up. So where the couple have been labouring during the previous few hours, and often that birth can occur in that room, and that's a really nice thing. It doesn't always mean you do need to go to the theatre. Sometimes there is a recommendation to go to the operating theatre, but the obstetrician seeing you will discuss whether they think that's possible, and they'll discuss which of the two types of instruments, so whether that's a forceps or a ventouse. And again, that's an important part of that conversation, is just going back to the really understanding the why is that doctor recommending it. Because there's I think a misconception that we would recommend it if we didn't truly believe it was necessary, and that just doesn't happen. Midwives wouldn't ask us to attend a birth and to review a lady if they didn't think it was necessary, and we absolutely would never perform an instrumental or an assisted vaginal birth unless we truly believed it was the right thing. So at that point, really have that discussion and understand why are they making that recommendation, what sort of instrument are they recommending, and there will be a very clear reason why. Again, the lots of people think that the instruments are the same and they're kind of intertwinable, and they are very similar, but there is a very big important differences between the two, and which scenario and which situation we can use each in, and that's part of the decision making process. And then it's about discussing again, what are those alternative options, because there'll be a very small number of situations where the obstetrician will have a serious concern that something needs to happen quite quickly, but the majority of the time there will absolutely be time for you to have time on your own without a midwife or a doctor present to have a discussion with your birth partner about if it's whether it's okay and the right thing for you to go ahead with, and to think through those risks and benefits of that assisted birth. And I think what's really nice is it does mean for you that lots of the same elements that are usually in a birth plan are still possible, like delayed cord clamping and immediate skin to skin, and having the lights dimmed and a very calm birth environment are still very possible, because we are just trying to replicate and and I don't know what other word I would say, reinforce vaginal birth as much as possible. We're just trying to replicate the same birth mechanism. We're just trying to help along a little bit. So I don't know if that helps a little bit, but I do think it's something that I really am fond of, because I think it's a part of something that we really can help a mother to achieve vaginal birth, and that keeps future pregnancies lower risk, which is just fantastic.
Yeah, definitely. And I think that's a really lovely point about the kind of looking at that birth plan or that couple's birth preferences, and how so much of that can copy across. So actually, although the birth is being assisted, and I love that term assisted rather than instrumental, because that really is what it is, isn't it? Mum is still doing all of that amazing physiology and all of her incredible pushes, and then your role is to assist with that mechanism and that vaginal birth. And then all that other stuff that can come in. And I love sort of encouraging parents to still have their music of their choice playing and things like that. And that can happen even in a theatre setting. So less needs to change than sometimes we think when we think about kind of birth intervention, for sure, which is lovely.
Yeah, and I think we're getting better at emphasizing that, and that's through lots of better antenatal education, really, having a plan. So if I'm recommended to have an assisted birth, what are the elements of my birth preferences I'd like the doctor, so the obstetrician, to know? I would like still in whichever setting, and like you said, that's lots of things are absolutely possible in the operating theatre, whether that is a vaginal birth or a cesarean section. Lots of things can be part of your birth preferences. They will still be possible. Just make sure you mention it, because then we can support you.
Yeah, absolutely. And that comes back to us all being there for the same role and the same end game, which is your birth experience and keeping you lovely and safe and having a positive experience. Now, Ellie, we've talked loads about your role, and I'm sure everyone agrees that it's super exciting and a wonderful, wonderful job that you're doing for us all as women. But what do you enjoy the most about being an obstetrician, if it is possible to limit it to a few things, I suppose?
So I think the variety and the unpredictability of the job is actually a really exciting thing to be part of. And I think every single pregnancy, every woman, every baby, every birth is completely different. And I think for me, that provides an opportunity to recognize that and to enjoy that part of my job. So to enjoy the fact that I don't just go to work and see a lady with a condition, and in medicine sometimes we do get very condition focused, but that's not the same in maternity, because we do use all of the different influences such as social factors, the obstetric history, your medical history, the scan findings of your baby, the preconception care and counselling that you had. All of these are intertwined, and that's what makes each pregnancy so unique. And I think we're so lucky as midwives and obstetricians that we get to be part of those unique situations and see how birth evolves, because I think we know that there's so many twists and turns and surprises in both directions. So times when you say to a mother in the antenatal clinic, you are at higher risk of complication, and actually that complication, so the majority of the time, never occurs, and we see those pregnancies evolve and birth be a totally wonderful experience for lots of parents. So I feel so privileged to be part of that. I think that's such a magical thing to be able to do. I can't imagine doing anything else, but I'm really enjoying that. And I think I have always been passionate about obstetrics, but I've definitely noticed since having the opportunity to discuss with parents and really understand their birth preferences and really understand things that are important to them and really listening to them, I've definitely shifted my own practice. I
Amazing.
think I'm really enjoying not rewriting the story, but just recognizing that it's important we break down some of these barriers between obstetricians, midwives, low, higher risk care, all of these things, because I do think it's a continuum and a spectrum, and that it's not quite as black and white as I think we sometimes make out. There's a huge amount of grey, and it's really important that we recognize that there's lots of things we can do to support women to have a healthy pregnancy, a healthy baby. And that's what we're all here for, to make sure that mother and baby are safe and that their birth experience is something that they can really enjoy and feel is a positive one. Well, and their pregnancy experience, the whole journey really, isn't it?
Yeah, absolutely. Oh, I couldn't agree more, Ellie. And that whole journey being positive and empowering just sets you up for a more positive and empowering transition into motherhood, and then sets you up for that positive future. So it's also interlinked, which is why it's amazing to have people like you helping educate us in the right way to have those discussions and make those decisions. Now, Ellie, I always ask everybody that comes on the podcast for 3 top tips. And I wondered whether you could give us 3 top tips that you might give to women, perhaps in the beginning of their pregnancy or even maybe preconception, about making their pregnancy or birth decisions. It's going to be hard to narrow it down to 3, I think, but we'll give it a go.
So I am still a big believer in the question why, and I've mentioned that a couple of times today, but I think there are lots of things that we recommend, and I think we know what we're thinking in our head, and and the midwife knows, and we know what we're talking about, and we train for many years to do that. And sometimes we really don't explain exactly why we're making a recommendation, and truly explain why the risk is more or less, or what the pros and cons are, what the benefit is in this particular case, why it's being suggested this time or in this way, because that does vary even from pregnancy to pregnancy for some women. So, and that actually does vary along the pregnancy journey. So you may be told earlier on in your pregnancy that we don't recommend a cesarean section, and then suddenly later on you're recommended a cesarean section. And that can be really conflicting information, and it's because something shifted. But understanding why, I think, is such an important tip. If you keep asking that question until you feel like you do understand the decision that you're being asked to make, should help. And that's all the way through to preconception, like you said. So why are you being asked to take folic acid, for example? If you know that, you'll invest more into it. You might be less likely to forget. You might be more inclined to start taking that medication, or for whatever other reason it is during your pregnancy. So I like that one. That's probably my biggest tip, is to make sure you don't just do what you've been told, because that's a very good patient or expectant parent thing to do, but it's often important for you just to have that closure, to know exactly why the doctor or the midwife has recommended that.
Like being an inquisitive toddler, isn't it? They would never do anything without understanding why.
Yeah, exactly. So and I think that's, and then it's taking, and because you will know your reason and you'll know your own situation. So that's why my sort of second thing is that you have to personalize the situation to you. And that's really hard, because I won't know that as an obstetrician, or a midwife won't know some of those really subtle things in your history or your birth experience to date that are really important, that will impact you and your situation. So you have to really personalize it, because often research and studies and audits don't take into account all of those human factors. And I think it's important for you to tell us if there's something particularly for you as a couple, or in your medical history or your obstetric history, so your pregnancy history to date, that is going to impact your decision making, but also impact the situation that you're in, or the choices that you might make, because then we can help you, because we can have that discussion. So a bit like I talked about earlier with for example, the driving after a cesarean section, those are really personalized elements of a decision making process. And it's important that we know about those, because some of the time, although we do have your medical history, we don't always realize how important some of those things are to you. And I think it is your pregnancy and it's your baby and it's your birth. So I wouldn't want you to feel like you were being forced down a decision that was right for somebody else but wasn't right for you. So just make sure that you have asked, does it, does it change things that I personally feel about, X? I personally am really passionate to breastfeed. Does this change? For example, I think just a little example, because the answer might be yes or no, but we might not have thought that you would want to be, that would be important to you. And that's not because we're bad doctors or midwives, that's just because everybody is different. And if you're on call, you might go from room to room and you might meet a couple that have having a discussion about an induction, and then you might meet another couple who are coming in to talk about a previous cesarean section and what their birth plans are this time. And you do have to flip your brain quite quickly, so it's helpful if you can just understand that that's what we're trying to recognize, that everybody is individual, but sometimes we do need a help with that. So please let us know if there's something that we need to know, because then we can really try to do our best.
Definitely.
And the third thing, you asked for 3, didn't you? So
yeah,
I think really do take your time to make a decision where you need it. So like I said before, I think there's very few situations, and they do happen in maternity, but it's rare that there is such urgent situations where we are so worried about you or your baby that decision has to be made very, very quickly. And if it's a decision that can be allowed for a little bit of time, take that time to fully consider and discuss with your birth partner and your support network. Read the written information that you're given. Ask for access to different resources. So whether that's resources of national guidelines, find out those numbers that we talked about. So really understand the numbers and why they're relevant to you. And if there's any way that you can have more personalized numbers, and then just take the time to make sure it's the decision that's right for you, because nobody would want you to make a snap decision that isn't right for you. There'll be some circumstances where that may be the situation because of the urgency or an emergency, and that should be explained to you afterwards. So someone should come and explain why that was the case later. But the vast majority of times, things don't have to be decided on the day, particularly at the moment when you may feel slightly isolated from your support network at an appointment or at a scan, or during the early part of the labour. So that's absolutely fine to ring someone to say to the midwife or the doctor, do you mind just stepping out for a few minutes and letting me have time to discuss it in private? And we'll let you know. And nobody will ever be offended if you don't accept something we offer. We're only here to provide you with the options for you to be able to make decisions and choices that are right for you, because this is your pregnancy, it's your baby, it's your birth, and it's not for us to decide what's right for you. We're just here to support you.
Amazing. That's so great. Thank you so much, Ellie. And I hope that anyone listening feels a lot more reassured if they do find that they meet an obstetrician along their journey, and feels more confident in asking those questions and navigating their choices in the right way for them. So thank you so much for sharing your knowledge and your ethos, because I absolutely love it, and I know that all the ladies who you are supporting are very, very grateful for your care and expertise as well. So thanks for taking some time out for us, Ellie.
Oh, well, I'm very glad to. I've loved coming to have a chat with you, Pip. This has been absolutely brilliant. I do love my job. I love everything about it. So spending an extra hour talking about everything obstetrics is one of my favourite things to do. So if you ever want me to come back on, I'll be happy to. And to everyone listening, if you are pregnant at the moment, have the best pregnancy, have the best journey, and do not be worried about meeting an obstetrician. We are only here to support you. And for whatever reason, if you do need to speak to one of us, just your midwife will always be able to get in touch. And there's always information on the Royal College of Obstetricians and Gynecologists website that's evidence-based information for you if you need anything else.
Amazing. Thanks so much, Ellie. Have a lovely afternoon.
Thank you, Pip.